Okay. Let's see. Just set up. Oh, it says fibrino necrosis. Inflammation. Maybe let's read this one again. This one read already. So go further here. Monocyte, lymphocyte, RER looks like thumbprint, granules, cluster, destination, types of inflammation. It's done already. Granulation tissue, keloid, IgM, tissue repair. Histiocytosis, inflammation. Okay, I read from here. So let's set up the still working. Maybe this is here better. Exercise notes and review of inflammation. So ISR put in whole blood into a cylinder and see when it settles. The higher the density or weight, therefore settle pretty quick and therefore have an increased sedimentation rate when stuck together and looks like coils, roulets. When aggregated together, increased sedimentation rate, which is increased IgG and fibrinogen, includes every acute and chronic inflammation there is. What causes red blood cells to clump? IgM, because the negative charge normally keeps red blood cells from stick to EO. IgM is a lot bigger co-agglutinins associated with IgM antibody, leading to agglutinin. This is why in cold weather, so you get Raynaud's phenomenon. The lips, nose, ears, toes, fingers turn blue. Ah, okay. IgM is a lot bigger, so co-agglutinins associated with IgM antibody listed to agglutinin. This is why in cold weather you get Raynaud's phenomenon, like the lips, nose, ears, toes, fingers turn blue. IgM antibody can cause cold agglutinins, leading to ischemia. Okay. Another type of clumping of IgM are cryoglobulins. Igs congeal in cold weather. IgM antibodies do the same thing. So high associated with Hep C with cryoglobulins. Multiple myeloma increase ESR because increase IgG. So with the Waldenstrom's will increase IgM. So we see Waldenstrom macroglobulinemia. Now again, so extrasinus and review of inflammation ESR. So putting whole blood into the cylinder and see when it settles. The higher the density or weight, therefore settle pretty quicker and therefore have an increased sedimentation rate. So when stuck together and look like coils, roulets. So when aggregated together, increase sedimentation rate, which is increased IgG and fibrinogen. Includes every acute and chronic inflammation there is. What causes the red blood cell to clump? It's IgM because a negative charge normally keeps the red blood cell from stick to heal. IgM, on the other hand, is a lot bigger, so co-agglutinins associated with IgM antibody, leading to agglutinin. This is why the cold weather, so you get Raynaud's phenomenon. So lips, nose, ears, toes, fingers turn blue. IgM antibody can cause a cold agglutinins, leading to ischemia. Another types of clumping of IgM are cryoglobulins. So, so Ig is congealed in the cold weather. IgM antibodies do the same thing. High associated with hepatitis C, so with cryoglobulins. Multiple myeloma, which increase the ESR because increase the IgG. So with Waldenstrom, we see IgM, which is Waldenstrom macroglobulinemia. So acute appendicitis. Get complete blood cell count and want to see absolute neutrophilic leukocytosis, meaning that you have an increase of neutrophils in the peripheral blood. Also looking for toxic granulation and a left shift, assuming you start from myoblast on the left and eventually form the segmented neutrophil on the right. Normally go left to right on maturation. Therefore, with the left shift, this means that we go back in immature neutrophils. Definition is greater than 10% band neutrophils is considered the left shift. So all the neutrophils are bands. So if you have just one metamyelocyte and one myelocyte, it is automatically considered the left shift. In acute appendicitis, there is an absolute increase in neutrophils with a toxic granulation and a left shift. Again, acute appendicitis. Get complete blood cell count and want to see absolute neutrophilic leukocytosis, meaning that you have an increase of neutrophils in the peripheral blood. Also looking for toxic granulation and the left shift, assuming you start from myeloblast on the left and eventually form the segmented neutrophil on the right. Normally go left to right or maturation. Therefore, with the left shift, it means that you go back to immature neutrophils. The definition is greater than 10% band neutrophils is considered a left shift. So all the neutrophils are bands. So if you have just one metamyelocyte and one myelocyte, it is automatically considered the left shift. Okay, so right here. If you have just one metamyelocyte or one myelocyte, so metamyelocyte or myelocyte, so that's considered, so it is considered left shift. So in acute appendicitis, there is an absolute increase in neutrophils. So with toxic granulation and a left shift in acute appendicitis, absolute increase neutrophils with the toxic granulation and the left shift. Okay. Now most potent system for killing bugs, oxygen-dependent myeloperoxidase system. Myeloperoxidase is located in acidophilic granules, which is lysosomes. One a lot of lysosome in an acute inflammatory reaction because therefore there is a more myeloperoxidase around for killing bugs. This is what toxic granulation. Therefore, toxic granulation ensures that there is enough myeloperoxidase to work that potent system to kill bugs. Oxygen-dependent myeloperoxidase system. Okay, so most potent system for killing bugs, which is oxygen-dependent myeloperoxidase system. Killing bugs, which is oxygen-dependent myeloperoxidase. So remember the enzyme myeloperoxidase system. So myeloperoxidase is located where acidophilic granules, which has a lysosome. So in lysosome, killing bugs is a lysosome, correct? Lys stands for lysis. So they have an enzyme called this myeloperoxidase system. One, a loss of lysosome in acute inflammatory reaction because therefore there is more myeloperoxidase around for killing bugs. So this is a toxic granulation. Therefore, toxic granulation ensures that there is enough myeloperoxidase to work that potent system to kill bugs. So oxygen-dependent myeloperoxidase system. Okay. Now talk about fluid hemodynamics. So edema assess fluid in the interstitial space, which is extracellular fluid. ECF, this is outside the vessel. Types of edema. Non-pitting edema increase the vessel permeability with pus in the interstitial space. Pus, so exudate. Lymphatic fluid is another type of non-pitting edema. Blockage of lymphatics leads to lymphatic fluid in the interstitial space, so pits early but eventually becomes non-pitting. So exudates and lymphatic fluids does not pit. So talk about types of edema, non-pitting edema, pitting edema, something like that. Now non-pitting edema increase vessel permeability with pus. in the interstitial space, first which exudate. So lymphatic fluid is another type of non-pitting edema. Blockage of lymphatics leads to lymphatic fluid in the interstitial space. Pits early, but eventually becomes non-pitting. Early stage which is pitting, but then after that non-pitting. So exudate, which is pus, and lymphatic fluid does not pit. So keep in mind exudate, which is pus, and lymphatic fluid. So pus and lymphatic fluid, that's a non-pitting edema. Non-pitting, which increase the vessel permeability. So interstitial space. Okay. Now talk about pitting edema, which is transudate. Transudate. So like for example, in right heart failure, swelling of the lower extremity, fluid in the interstitial. Fluid in the interstitial space. Well, interstitial space. It's a fluid. So that when they said translates the spit, for example, right heart failure. But what interstitial space a little bit confused here. If the pus get into interstitial space, the pus is a fluid, man. If like that, if by naked eyes, we cannot tell that is translate or exudate, isn't it? I mean, the kind of fluid, if we don't see directly. But actually, by the clinical examination, we can see this and non-pitting, pitting which is with precious and they still leave indentation, I think. Now, so there are three things can cause edema. So exudate, lymphoedema, and lymphedema and transudate. Okay, three things which exudate, such as pus, lymphedema, which is lymphatic blockage, and the last which is a transudate, which is pitting edema. Transudate is only one thing that can cause a pitting edema. Transudate. Now, transudate, which is pitting edema, transudate deals with the stalling force. What keeps fluid in our blood vessel? Keep fluid in our blood vessel, which is albumin, is oncotic pressure. The albumin is a type protein, so oncotic, they create the oncotic pressures. 80% of our oncotic pressure is related to the serum albumin levels. Anytime there is a hypoalbuminemia, which is low albumin in bloodstream, so low that, and then easy to suck the low albumin or what keeps fluid in our body. This albumin which is the creator oncotic pressure. 80% of our oncotic pressure is related to albumin, serum albumin. Anytime there is a low albumin in the bloodstream, so low, and then the fluid from a vessel escape a vessel and they get into interstitial space. So that's why the transudate, they leak in a transudate have like a protein less than 3 grams per deciliter, leaking into interstitial space via capillaries and venules of kidney edema. So normally hydrostatic pressure, I'll talk about hydrostatic pressure. So which is due to water trying to push the fluid out. So oncotic which is keep the fluid in the vessel, but hydrostatic fluid pressure which is push the water out, push fluid out of the vessel. Therefore, in the normal person, oncotic pressure is a winning, which is keep the fluid in. Therefore, a decrease in oncotic pressure, so which is a decrease like that, so it doesn't increase hydrostatic pressure will lead to transudate. So because transudate which is get the fluid escape from the blood vessel get into the interstitial space. So that's why they cause this is edema. Uh, so that's why the older patient they are a little bit upset, disappointed. If they have thing like this, therefore increasing oncotic pressure is increase. So decrease oncotic pressure, so lead to the increase hydrostatic pressure. So that's why uh, the fluids escape, from the escape out of the vessel get into the interstitial space. So they cause the edema. This is a transudate. Okay, they cause the pitting edema. Now, albumin is a MAC in the liver. So, with the chronic liver disease, like a cirrhosis, have a decreased albumin level, decrease which decrease oncotic pressure. So, can you vomit it down? No. What? Can crab it down? Malabsorption syndrome, or can pee it down? Nephrotic syndrome. So, can come off our skin is a third degree burn because losing plasma. Another possibility, low protein cow, low intake is seen in the cases in or kids have a fatty liver and decrease decrease protein intake leading to low albumin level. So which is email nutrition, which is low protein, so which is unable to keep the low albumin. Low albumin cannot keep the fluid into to the vessel, right? So fluid get out of the vessel, which is transfer the fluid to kidney edema. If like that, how about a patient have a heart failure, right heart failure? It also cause a kidney edema. And what mechanism? Because I think due to too much of fluid, right? Because too high the sodium it keep the water into the bloodstream, so increase hydrostatic pressure. So example, person with the myocardial infarction 24 hours ago and he died and he has a fluid come out. He transudate because increase hydrostatic pressure and left heart failure due to myocardial infarction. So things are backed up into the lungs because cardiac output decreased and the systolic volume increased and pressure on left ventricle increases and the pressure is transmitted into the left atrium to the pulmonary vein. A milliliter pressure keeps backing up and the hydrostatic pressure in the lungs approaches the oncotic pressure to 25 millimeter milliliter. No. And the translate starts leaking into the interstitial space, which leads to activation the J receptor, which will cause dyspnea. So leads to full blow in alveoli and pulmonary edema, which is what it is. Again, person with myocardial infarction 24 hours ago died and he has a fluid come out. But it's transudate because increase hydrostatic pressure. Why? Because increase hydrostatic pressure. So left heart failure due to myocardial. So things back up into the lungs because the output decrease and diastolic volume increase and pressure on the left ventricle increase. The pressure is transmitted into the left atrium and pulmonary vein. Pressure keeps backing up and nitrogen pressure above the oncotic pressure 25 milliliters and transudate starts leaking to starting because the canal both decreases and diastolic volume increases and pressure on the left ventricle increases and the pressure is transmitted into the left atrium to the pulmonary vein. So a little pressure keeps backing up and hydrostatic pressure in the lungs approaches the oncotic pressure 25 milliliters. So hydrostatic pressure in the lung approaches oncotic pressure 25 millimeter and the transient starts leaking to interstitial space which leads to activate the J receptor which will cause dyspnea, leads to full blow in alveoli and pulmonary edema. So which is what it is. Now talk about venom from the bee sting. So bee sting on the arm leads to activate so venom from bee sting on arms leads to activate or disactivate due to anaphylactic reaction. Phase 12 histamine being propagated. Type 1 hypersensitivity because this anaphylaxis is a type 1 is a fast reaction causing tissue swelling. Treatment airway 1 over 1000 aqueous epinephrine subcutaneously. Now cirrhosis of liver with swelling of the legs. The transudate mechanism decrease on cortic pressure cause cannot synthesis albumin with the swelling of the legs. Transudate. So talk about cirrhosis of the liver. So because cirrhosis, the low albumin increase hydrostatic pressure, low albumin. So that's why the water so get out of the vessel and you give up interstitial space. This is transudation. That's what feeding edema. This is swelling in the legs. And transudate mechanism decrease oncotic pressure because cannot synthesis of albumin. So increase hydrostatic pressure because of portal hypertension. So there is of the liver. Yeah. If we treat well, cirrhosis of the liver. And the portal when empty into the liver, in this case, it cannot, and there is increased hydrostatic pressure pushing the fluid out into the peripheral cavities. So there are two mechanisms for acid edema in the legs, decrease in non-cortic pressure. Read again. Cirrhosis of the liver with the swelling of the legs, translate mechanism. So decrease on cortic pressure because cannot synthesize albumin and increase hydrostatic pressure in the portal because of portal valve hypertension. Increase portal hypertension. There is a cirrhosis of the liver. Portal vein empty into the liver. In this case, it cannot. There is increased hydrostatic pressure, pushing fluid into the interstitial. So beating the legs in the oncotic pressure now. Patient with the dependent kidney edema. Patient has a right heart failure. Therefore, increase hydrostatic pressure with right heart failure. The blood behind the failed right heart is a venous system. Cirrhosis of the liver is due to decrease oncotic pressure. Patient with dependent kidney dependent patient right heart failure. Therefore, increase right heart failure. Right? You know what the function of right heart? So increase the hydrostatic pressure, right heart failure. The behind the heart failure varies in the system. Okay, cirrhosis liver decrease on cortisol. À, if mà right heart failure là due to increased hydrostatic pressure, but with the cirrhosis of the liver là due to decrease oncotic pressure. Okay, two main, two different two main mechanism. Okay, so with the cirrhosis of the liver due to reduce synthesis of the albumin, so reduce oncotic pressure. That's a main mechanism. Then after that, get transudate, which is the fluid escape out of the vessel. So from the vessel, they get into interstitial space. So that's why they increase. So they cause a kidney edema. But for the right heart failure, which is increased, um, because they trap the fluid in the venous system, so they increase the hydrostatic pressure. Okay, with cirrhosis of the liver, which is due to decrease oncotic pressure. Now, modify radical mastectomy of the breast with the non-kidney edema. So this one due to lymphedema. So this a non-kidney, huh? We see the swollen, but non-kidney other causes like bankruptcy, lymphogranuloma, venereum, subtypes of chlamydia trachomata, scarring tissue, and lymphatics, leading to lymphedema of the scrotum, lymphatic inflammation, carcinoma of the breast. So pour the orange, which is orange color, pour which is the water of the breast. So this with dermal lymphatic plug with tumor sex leads to dimpling and looks like the surface of an orange. Most common cause is lymphedema. So post-radical mastectomy can also run risk of lymphangiosarcoma. Now modified radical mastectomy of the breast. This because it's a lymphedema, so that's a non-pitting. Other cause, so like a pancreatic or lymphogranuloma, venereum, subtypes of chlamydia trachomata, scarring tissue, and lymphatic leads to lymphedema of scrotum, lymphatic inflammation, sarcomas, carcinoma of breast, powder orange of the breast, used with dermal lymphatic plug with tumor access leads to dimpling and looks like the surface of orange. Most common cause lymphedema. Post-radical mastectomy can also run risk of lymphangiosarcoma. Okay, and last time talk about renal physiology, ECF over ICF. Okay, maybe stop right now. So next time read more. Would you like to read more this one? Or maybe read more a little bit and then read again later. Renal physiology, extracellular fluid, intracellular fluid, extracellular fluid compartment, intracellular fluid compartment, intra which is inside the cell, extracellular fluid which is outside the cell. So if outside the cell compartment which is extracellular fluid compartment, they have a two subcompartment. Number one, which is inside of the vessel, and number two, which is interstitial space, which is between of the cells, right? So in the vascular compartment and interstitial space. So if talk like that, so we know fluid most likely inside the cell. So that's why they contain around two-thirds of the total body fluid, and the one third which is extracellular fluid. Okay, extracellular fluid is equal one-third of the total fluid in the body, total body fluid. But in the extracellular fluid, and then between the interstitial space and in the vessel, which one more? So the answer is the interstitial space, even more fluid than that. So interstitial space, which is around two-thirds. So two-thirds of the extracellular fluid, and the rest one-third of the extracellular fluid, which is inside of the vessel. So one-third, which is that's a vascular compartment in the vessel. So for example, now the question is how many liters of isotonic saline do you have to infuse, okay, to get the 1 liter in the plasma? In the plasma, which is where into in the vessel, right? So if now we see 1 liter in the vessel, then 1 liter like that, then have two liter in interstitial space. So then totally 3 liters in extracellular fluid, right? So we have, and then the intracellular fluid, which is double, then extra 3 multiplied by 2 equals 6, like that. But they just ask how many liter isotonic saline do you have to infuse. So then the answer is 3 liters, because 1 liter we know the same plasma, and then in the interstitial space, which is double than that, equal to 1 plus 2 equals 3. So the answer is 3 isotonic saline liters. So we remember that. Now osmolarity. Osmolarity measures solute in the fluid due to 3 things: sodium, glucose, and BUN, plus urea, nitrogen. So urea cycle is located in the liver, partly in the cytosol and partly in the mitochondria. Usually multiply sodium times 2, because 1 sodium and 1 chloride. So osmolarity measures solutes in the fluid due to 3 things: sodium, glucose, and BUN. Osmolarity, which is 3 things: sodium, glucose, and BUN. So which is plus urea nitrogen. So urea cycle is located in the liver, partly in the cytosol and partly in the mitochondria. Usually multiply sodium times 2, because 1 sodium and 1 chloride. Fluid and hemodynamic. So normal sodium is the 135 to 140 range. So times that by 2. So for example, 140 equal multiplied by 2 equal 280. For glucose, normal is around 100. Divide that by 18. 18, what is 18 for? 18 maybe water. What? Let's say it's roughly 6. Roughly 5, right? Let's say 100 divided by 18. Let's say 100 divided by 20 equal 5, roughly 5. So that's not contributing much. And BUN, which is located in the liver, blood, urea, nitrogen, part of cycle is in cytosol and part in mitochondria. The urea comes from ammonia. That ammonia is gotten rid of by urea, because the end product of urea cycle is urea. The normal is about 12 divided by 3, so we have 4. Therefore, in the normal person, sodium is controlling the plasma osmolarity, which is 280. To measure serum osmolarity, double the serum sodium and add 10. Add 10, 10 come from what? I guess 10 come from the glucose, contribute 5, and BUN contribute 4, which is around 9, you know, roughly around 10. So to measure serum osmolarity, which is double the serum sodium, for example, if mà we know serum sodium for example 135 to 140, let's say we see this around 136 multiplied by 2, cái like that. 36 2 equal to 72. 272 plus 10 equal to 82. So then serum osmolarity equal 282. That's the way they calculate. Okay, now talk about osmosis. Osmosis is two of these three are limited to the extracellular fluid compartment. One can equilibrate between extracellular fluid and intracellular fluid cross the cell membrane and minus urea. Two of these three are limited to the extracellular compartment. One can equilibrate between extra and intracellular fluid cross the cell membrane. Urea. Sodium glucose and BUN. One can equilibrate between extracellular fluid and intracellular fluid across the cell membrane and urea. Therefore, with the increased urea, if increased urea, it can equilibrate equally on both sides. To it will be equal on both sides. This is due to osmosis, because sodium and glucose are limited to the extracellular fluid compartment, which is in the vessel interstitial space. Then changes in its concentration will result in the movement of water from low to high concentration. Opposite of diffusion, for example in lungs, 100 millimeter mercury in alveoli of oxygen and returning from the tissue is 40 millimeter mercury per oxygen. 100 versus 40, which is a bigger, 100 is a bigger. So via diffusion, oxygen moves through the interstitial space into plasma to increase oxygen to about 95 millimeter mercury. Therefore, in diffusion, it goes from high to low, while in osmosis, it goes from low to high concentration. Now talk about osmosis. Two of these three are limited to the extracellular fluid compartment. One can equilibrate between extracellular fluid and intracellular fluid across the cell membrane. Urea. Therefore, with the increased urea, it can equilibrate equally in both sides. So it will be equal on both sides. This is due to osmosis, because sodium and glucose are limited to the extracellular fluid compartment. Then chances in its concentration will result in movement of water from low to high concentration. The opposites of diffusion, for example, in lungs, 100 millimeter mercury and viola oxygen, and returning from the tissue is 40 millimeter, 100 versus 40, which is a bigger, 100 is bigger. So diffusion. Oxygen move from interstitial plasma and increase oxygen about 95. Therefore, in diffusion, it go from high to low, but in osmosis, which is go low to high concentration. Example, in the case with hyponatremia, water goes from extracellular fluid into the intracellular fluid. In the low sodium bloodstream, so low you cannot keep the water in the bloodstream, so inside the cell, sodium which it is suck the water So it gets swollen inside the cell, which is global. Therefore, it's expanded by osmosis. Now, make believe that the brain is a single cell. What will see? It causes cerebral edema and mental status abnormalities via long law of osmosis. The intracellular compartment of all the cells in the brain would be expanded. Resemble hyponatremia, then opposite. So too much water, they suck the water uh, outside of vessel, get inside of the vessel, which is from interstitial vein or inside the cell into that, and make the cell shrunken. So which is contracted the intracellular. So in the brain, it will lead to contract the cell, therefore mental suffer abnormality. Therefore, hyper will get mental status abnormality of the brain. Oh wow! Keep in mind that, huh? Low sodium or high sodium still cause mental status change. So that's why the fluid to make the very important to keep the sodium level in the bloodstream normal, very important. Talk about DKA, have a 1000 milligram large amount blood sugar. Remember that both sodium glucose are limited to the extracellular fluid, which is you know inside the bloodstream compartment. You would think that glucose is in the intracellular fluid inside the cell, but it's not. You think that since glycolysis occurs in cytosol which is inside the cell, therefore glucose in the intracellular fluid again is not. Because what? Because to order to get into the cell, the intracellular, glucose must bind to phosphorus, generate to TCP, which is metabolized. It's the same with the fructose and galactose, which are also metabolized immediately. Therefore, there is no glucose, fructose, or galactose per se intracellularly. Oh, so which is barely or no glucose, fructose, or galactose inside the cell, huh? So with the hyperglycemia, which is high glucose in bloodstream, then which is a high glucose in bloodstream, which is in the extracellular fluid, specifically which is inside the vessel. So then they will suck the water. So the water will move from inside the cell, get into the extracellular fluid. So that's why the inside the cell will contract, which is shrunken. You know, therefore the serum sodium concentration will because the water get in and make the sodium concentration in serum will go down. Ah, that's important. This is called delusional hyponatremia. So which is what happens to the serum sodium, which is what happening with serum sodium. Okay, so in the case of the DKA cause hyperglycemia, what we cause hyperglycemia, then the cause is a hyponatremia. Hyponatremia or hyponatremia, both of them cause the mental status change. because it cause the brain get trouble. The brain if high sodium in the bloodstream, right, which is we suck the water out of the cell. Just think about the brain, just one cell like that. You suck out, and then the brain shrunken. But if hyponatremia, which is low sodium bloodstream, so then the water will escape. Which is from water move from the vessel get into the brain, which is into the cell inside the cell, make the brain swollen, also change mental status as well. Very important. So there are the two things that control water in the extracellular fluid, so which is sodium and glucose. But a normal situation, sodium controls. So in normal situation, sodium will control. But in case if the like the diabetes, something ketoacidosis, DKA, thì then sodium and glucose control. So urea does not control water movements because it's permeable. Urea, which is they cause equilibrate both sides, so can get through the both compartments and have equal concentrations on both sides. So even we have three things, but the two things is important, which is sodium and glucose. Controls osmosis. I mean, right? So because the urea they can cross permeability to the cell membrane, so that equilibrate both sides equally, no problem. But sodium and glucose, most likely they stay in the extracellular fluid, which is outside of the cell. So if anything change, they can change the fluid, so they can affect to the brain. Keep in mind that. So maybe we stop now. Okay, so I think that's good enough. So maybe talk more later. Thank you.